All right, welcome everyone. I'll go ahead and kick us off. My name is Adam Goss. I'm a project manager with Mental Health Colorado. Thank you everyone for taking the time out of your Thursday afternoon to join us for our reports and updates meeting. In this meeting, we focus on programs and organizations across the state that are working to disentangle mental health in the criminal justice system, something that's very near and dear to our mission at Mental Health Colorado. So I would just like to present our presenters for today is going to be the team of Denver Health and Hospital Authority Adult Psychiatric Services. Our presenters are Dana Kreindler, Amanda Klahr, Ashley Hill, and Carrie Pink. I believe they're having some video technical difficulties, but they should be able to share a screen. And with that, I will go ahead and pass it over to Dana if everything's functioning properly for you.
Yes, I will share the screen now.
I'm going to jump in. Hello, everyone. Thank you so much. My name is Amanda Klahr. I'm the nursing director for inpatient psychiatry. And so we're so honored to be here today. Dana is going to present work that we're doing in regard to our bed lease agreement with the Office of Behavioral Health and with a patient population who is receiving competency restoration. This is a patient population that we are providing psychiatric care and doing this other competency restoration piece. I'm excited for Dina to present and Ashley, so it's the three of us here today. Because what they're showing is a model of care delivered by occupational therapists. This is innovative care and a model that we're proud of. We'll provide the presentation, and then please, if you have additional questions with caring for this patient population and how we're doing it on an inpatient unit, we'll certainly be open to those questions as well. So thanks again, we're honored to be here. And please enjoy the presentation.
All right, can everyone see my screen? Yes, okay. All right, so I'm Dana. I've been here at Denver Health for 3.5 years. I've been an occupational therapist for about 7 years. And then as Amanda had said, we're gonna kind of look at the occupational role in competency restoration here in an adult inpatient psychiatric unit. So kind of to get a little background, so Denver Health's contract with the Office of Behavioral Health, and I'll just call it OBH. We started this back, there we go. Okay, back in June of 2020, and we are currently a 45-bed unit, and about right now we are serving 22 beds are serving the OBH population, so about half. Throughout this last few years, we've served over 120 patients through the OBH contract. And then as Amanda had said, the two occupational therapists, myself and Ashley, are the leaders for the training of the competency restoration. So just kind of a little background of why Denver Health, is an appropriate place for our OBH patients to come. Denver Health is a safety net hospital serving the entire Colorado community. We are taking adults 18 years and older. We are typically kind of a short-term acute hospitalization for psychiatric stabilization and then discharge our patients back to the community. And of course, through this contract have been helping even some of our patients with OBH discharging to the community, depending on what's happening in the legal system. A lot of our patients, both our incarcerated patients as well as our community patients, are on court-ordered medications or emergency medications. So that kind of gives, an appropriate setting for these individuals that are coming from jail that may not be taking medications. I'll kind of get into a little bit more of that in a few slides. And then just a little background, our unit comprises of an interdisciplinary team. So we have psychiatrists, we have psychologists, occupational therapy, social worker, nursing, sometimes music therapists. So not only are these patients being provided with groups for specific competency restoration, they are also being provided with general mental health groups to help with kind of coping skills. So one may ask why occupational therapy is doing competency restoration. For those that don't know, what OT is or not too familiar, this is kind of our domain and process. So using our occupational therapy practice framework, in general, OTs focus on ways we occupy our time. So we frame it as our job of taking care of ourselves. In this setting, our focus is to help individuals continue to complete activities of daily living and quote their jobs in their life despite living with a mental illness. So when the contract was presented to our unit, it made the most sense that OT and the OT interventions would be the most appropriate kind of leaders and educators for this population. And then OTs also educate, plan, and help assist to restore individuals to competency and increasing overall well-being kind of prior to them leaving us in their court process. So to get in a little more detail, we can look at more of our OT domain. So I'm going to focus on the highlighted sections and how OTs kind of have a big role in restoration. So we can look at occupations, we have activities of daily living or ADLs, and then health management. So we review jail documents to kind of better understand the behaviors around ADLs and health management of our patients that are coming to us, and how we can assist in encouraging patients to engage in these tasks while on our unit. We help patients increase participation in these areas that are expected to be in the courtroom and just generally within the community. And I'll go into a little bit more detail, I think in the next slide, how our interventions do help with that along with the restoration piece. So then we can look at performance patterns, habits, routines, and roles. We look at how incarceration has impacted several components of our patient's life. Also depending how long a patient has been in jail may impact, these habits, routines, and roles in significant ways. And then, a big thing we are seeing is many of our patients are coming to us that have been waiting in jail for 6 to 12 months for competency restoration. So of course, there is lots of decompensation that does come from that with ADLs, habits, and routines. And then of course, as I mentioned, a lot of our patients are coming not on medications, but have previously been. And so, of course, as we know, medications can greatly influence routines and roles that interfere with just general taking care of ourselves. And of course, that's where I mentioned earlier that Denver Health is a very appropriate place for these individuals because we can then get them on a medication regimen that helps with symptoms and progress through competency. So then we can look at performance skills, the process skills, and social interaction skills. For those that are familiar with the competency evaluation process, there's kind of two main sections that evaluators will focus on to assess kind of their current competency with court proceedings. And then the other section's ability to consult with an attorney in order to assist in one's defense. So our OT lens gives a unique view to help these individuals effectively build social skills, of course, verbally as well as non-verbally, and appropriately communicate with one's lawyers and other people that would be in the kind of judicial process. So a judge, and then of course, the forensic psychologist that's going to be doing the evaluation. So sometimes we'll just kind of, do like a role play kind of thing just to get get our patients to be more comfortable with that. And then lastly, we can look at client factors. So this, I specifically highlighted beliefs, of course, values and spirituality is an important piece, and wellness as well. But we do see a lot of our patients that have beliefs that greatly impact their legal charges and whether someone does become competent or remains incompetent to proceed. So we've gotten patients that believe that maybe they're God or that blood draws because of a medication management is causing memory loss, and retaining competency restoration training can heavily kind of, impact their ability to become competent. So I think, that's a big piece that we're working on with patients, obviously with medications to see if that's helping with certain beliefs. We do have many individuals that have very fixed delusions that of course are impacting their ability to kind of move forward. So it's just working with them and seeing how we can best support them to get through this process. I'll just put these all out. There we go. Okay, so kind of the process here at Denver Health. We provide 2 groups a week. We do have 2 units within this psychiatric floor, and 1 unit has a little bit more like acuity. So patients that may be a little bit more assaultive, that we don't provide groups on that side just because they might not be appropriate at that time to be engaging in groups. But then on our other unit, we do provide 2 groups a week. They're an hour long. And of course, we encourage participation. I think a lot of times, depending on one's mental illness and kind of that motivation is something that we really focus on. And then with all our patients, we then look at individual sessions and see who might be most appropriate for those. For example, patients that might be requiring like extra assistance because of memory deficit, intellectual disabilities, and then specific mental health symptoms, such as, like, as I mentioned, negative symptoms of schizophrenia or delusional beliefs. So we were given the national module or the national manual with the 16 modules. So we have based kind of a lot of our groups off of that, but as OTs, we like to be as creative as possible. So we've really expanded our program by having different kind of games that are working on building that factual knowledge, and then also kind of applying some of those facts to mock scenarios and so forth. But we also created this occupational profile. If anyone is interested in seeing our questions, I can send that to you after. But there are 12 questions that was created by myself and an OT that recently retired here at Denver Health. And it's to establish kind of patients' current understanding of competency restoration, their prior level of function, and kind of goals for treatment. So it's a little bit based off of module 1, if anyone knows module 1 from the manual, but just kind of general introduction to competency, but of course trying to do it in a more OT lens so we can see if, you know, patients are needing more sensory intervention. So if someone's getting very anxious about, you know, talking to their lawyer, what are some strategies that we can provide there? Kind of which leads into the occupational performance and evaluation process. So as I mentioned, Ashley and I don't just do competency restoration, we're doing general mental health groups on both our units. So of course, encourage all our patients to come to that. And then from that, we can do observations about seeing if they need extra kind of resources that might help get them through competency. And then formal assessments, which are listed below. And then every day, Monday through Friday, we have treatment planning with our interdisciplinary team. So talk about patients, how they're doing, you know, specifically with competency or in other groups. And then we also do formal OT assessments. Of course, we know their main goal is to go through restoration. However, you know, we do have a lot of individuals that we aren't too sure maybe of their learning style or even their cognitive ability. So we've got specific OT assessments that kind of help us find different strategies to help our patients. And yep, that kind of sums it up. So here's our contact info. And then any questions?
Hi, can you all hear me?
We can.
Yeah.
Okay. Hi, I'm Sonia Burns. I have a couple questions. Sorry, I jumped in a little bit late, so I don't know. Did you discuss if there's a set time frame that you all have to work within, or are you doing extensions on the orders for competency restoration?
let me see if I can answer that question. So we get admission packets that are sent to like the charge nurses that they will review and see if they're going to be appropriate for our unit. And if so, then the patients are transferred to us. Sometimes we're saying, you know, Joe Smith is going to be coming at 2 p.m. on Friday, but he doesn't get on the bus. So we end up not getting him, but he could come on the bus on Monday. So from that aspect, you know, it's not like we start day one of competency restoration. Sometimes we might have to wait, but I would say typically our patients are here between like 3 and 12 months. Some of them haven't had evals in a year. And so then it's our kind of push to be like, to get at least another evaluation, because obviously they should be done every 90 days. So yeah, I'd say every patient is pretty different, kind of depending on what their needs are. And of course, you know, if medications are a big component, that can take months to figure out what a good medication is. Hopefully I somewhat answered it.
Yeah, I mean, I was specifically thinking because I know Oregon just did the thing where a judge, I'm assuming a lot of people on this call saw that, like they're forcing people out of the hospital. They can't stay, you know, they've been there too long. And so now they're going to stick to timelines. And if you're not restored in that timeline, you'll be sent back to the county and they'll have to decide. So I just wasn't sure if there was like a, you know, 180 days, then a 60-day extension, and then time's up or whatever. Also, are you tracking, like, are you accepting, like, so I'm in Texas and we have diagnoses that are, you know, and I think this is somewhat universal, considered unrestorable, yet we're still putting them through competency restoration. So traumatic brain injury, neurocognitive disorders, dementia. So are you seeing that, or do you have a flat no if it's a unrestorable?
No, I think, yeah, we don't accept people with like really high level charges, but we'll accept anyone. I would say actually several of our patients do have diagnosed TBIs, intellectual disabilities. We do have some people that actually have been deemed permanently incompetent in the past and then go back through competency and then come to us and are either deemed, you know, incompetent to proceed or permanently incompetent. So it's all over the board, kind of there.
And then did you already say, like, so you're touching on the next thing, sorry, y'all. Like how many people you're finding are unlikely to restore or remaining incompetent? Like,
and just to clarify, here at Denver Health, no one here does the evaluation. So we, like a forensic psychologist from OBH reaches out to us, and typically now it's done over the computer. But yeah, to the restorability piece, we're not really seeing, like there's a certain amount of evaluations that are done until they're PITP or just continue to be incompetent to proceed.
Sonia, this is Amanda, and I wanted to respond a little bit more in depth to your question about potentially long stays. I was not aware of the ruling in Oregon. What we do see here and are patients who are here for perhaps 9 months, 12 months, who are incompetent, who develop medical comorbidities as well, and potentially block access to care to others. And so whereas they stay, we are not moving patients out. The question about the appropriateness of that length of stay, once deemed incompetent or once we determine that the psychiatric care that they've been stabilized, the hospital, I don't think the best use of the hospital is to hold patients, right, and to become a residential unit. That is something we do at this point, but it's also a conversation we want to have. We've had conversations with Vincent that have been so helpful, but one of the points he had brought up was, are our forensic beds blocking our civic beds, right? And so do we get into a situation where we can't pull in community patients because we're not moving our contracted patients? So it's a very interesting question and problem to solve. Are there any other questions that we can answer for this group, or even pieces about the contract, or how we've managed it for the past 2.5 years?
Did you all say what the cost is? Is there like roughly a daily rate in this program, or I don't know. I'm sorry, I missed like the first 5 minutes.
Cindy, are you inquiring about a bed cost?
Yes.
I'm sorry, yeah. As far as the contract is concerned, I don't think I can share all those details. Just can we check if there's anything in the chat, just so we don't miss anything?
I guess I'll stop sharing. There we go. No.
Well, if there is no additional questions from anybody, if anything comes to you, we'd be happy to provide contact information for Amanda, Dana, and Ashley here if you have any additional things that come to you. But if not, thank you so much to Denver Health for taking the time today to speak with us. It's very interesting to learn about the program, and we look forward to tracking and hearing about future progress. Thank you so much to everybody for participating today. Okay, great. Yeah, I will absolutely send over contact information, Sonia. But thank you again for taking the time briefly out of your Thursday just to learn a little bit about programs going around our state. And I appreciate you all. Have a great rest of your Thursday. Thank you.
Thanks, everyone.
Thank you, everyone.